It's a wonderful occasion to also introduce Dr. Julianne Santarosa from Dallas. I'm going to invite her for commentary later during the cases that we're going to show off. And she's from UT Southwestern, which is again a significant conflict of interest for me because that's where I did my residency. She's going to talk about access to thoracolumbar spine surgery and how this should be done and who should do this and how it's done well and safely. And so we have a couple of cases that we've selected to present here, and I'll ask Dr. Jerry Robinson to take the lead. He has actually two cases, and the first one takes us abroad, I guess, touristic medicine, or medical tourism as it's called. So again, today's topic will be access to thoracolumbar spines and when and how we should go from the front, and a couple of cases first, and then we'll switch to Dr. Santarosa and look forward to her talk. Jerry?
She's on. Sure.
We don't know yet, but you get started.
Cool. All right. Let's start with this one. All right, do we have access to the slides? Are they up? There we go. Awesome. So good morning, everybody. My name is Jerry Robinson. I'm an ortho spine fellow from Akron, Ohio. I'm one of the fellows here at Swedish. For everybody that tuned in for our previous spine arthroplasty defeats and triumphs, this was a case that had a little bit of discrepancy on what people thought should be the final outcome. So since we're discussing anterior spinal access, I'd be interested to see what people's thoughts are on this. Here we go. So 59-year-old male with years of low back pain with extension into the buttocks and down the right leg onto the top of the right foot. Denies any numbness or tingling, but states that he's having more pain than usual over the past few weeks. No traumatic injury, no bowel bladder symptoms, no weakness, has tried some NSAIDs. No previous history, but is a physically active CEO of a company and lives at home with his wife. So on physical exam, 5 out of 5 bilateral lowers, sensations intact, decreased reflexes, straight leg raise on the right, and decreased lumbar flexion. Here you can see the pathology down at L5S1. Just for completeness sake, we'll let that run. And there's our disc protrusion. And you can see this kind of high intensity zone right here in the posterior aspect. So right-sided L5S1 disc protrusion. The patients underwent multiple injections, including prolotherapy, stem cells, PRP, steroids. He's tried basically everything with some relief, but it's only been temporary. After a year of non-operative treatment, which included previous injections, he got a repeat MRI, and that was for ongoing low back pain, now with no radiculopathy. And here you can see the progression of this high intensity zone and resorption of that disc protrusion. So the patient decided to go to another country, medical tourism, for artifact.
I have a question. Can you go back?
Yes.
So before we go into the artificial discs, Dr. Cook, can I put you on the spot? I'll bring the microphone to you. What is wrong with this disc? Go back one more. It's cool that we have 2 MRIs. What is this called? And what do you see here on that MRI scan? What are these doctors treating?
Well, from the looks of it, there's so there's a bit of a central disc bulge, looks like an annular tear. I really don't see much in the way of lateral recess stenosis there. The disc does have some decreased water content, but it doesn't look terribly desiccated.
What's that bright spot in that disc? If you go back one, Jerry, again.
Well, I suppose that, I mean, it could represent an annular tear. It could also represent an infection, but
It doesn't act right.
Zach, no?
Just a no.
Just a no. Nathan, none of you were at the arthroplasty meeting. Aha. Had you been there? This is, Jerry, do you want to tell us what that bright spot is?
Yes.
It was not here in the room here. The bright spots is on the...
Yeah, the bright spot was not in the room. Oh, wow. So that little white spot that you can see represents the high intensity zone, which represents like an internal disc herniation into the annulus and tearing of the internal annulus.
It's a nucleus that basically herniates into the annulus and gets stuck in there. And in my generation, don't frown and look it up. It's widely published on. And this was held as a extensive reason for fusion surgeries, discography, and stuff like that. In the hunt for pain generators, this was one of the leading culprits. And this is a great case that Jerry has found there and pursued, because it does show what can happen to one of those HIZs. What happened then as you look at that second MRI scan?
Yeah, so you can see that there's further propagation of that. And
that posterior annulus is literally torn out. So this is a central disc herniation. So the best theory of these HIZs is intra-annular disc herniation that then has a water content. Basically, the cartilage cells die off in that area, but they can cause pressure and cause pain, and that then can herniate, like in this case, the posterior annulus. So before we go into disc replacement surgery, which is what happened here. A disc replacement is a pretty radical thing. Zach, in Canada, you have evidence-based medicine there in many of the provinces. What would you do in Canada for a patient who has no neurology, has back pain? Assume this is, and I think Jerry got this across, this is a super high achiever. This is a man who owns a company, and he has means. I think he has a jet. He's not in this room. And he has back pain and some buttock pain.
Initially had butt pain, but now does not have any buttock pain a year later after all of these injections that I have up.
And one of your typical provinces in Canada, what would you be told to do?
Most likely not a disc replacement, maybe just a microdiscectomy.
Bingo. I mean, this is exactly Maryland.
Yeah, I mean, at most a microdisc, I would probably tell him not to have surgery. I mean, I would definitely advise him against having anything major and invasive, because he's going to set himself up for a lifetime of pain by doing that.
And New Mexico?
A third of what they said.
Rod, in a board exam situation, if you were shown this case and somebody would say disc replacement as an examiner, what would you do to that candidate?
They probably wouldn't do very well.
In organized neurosurgery, what is the teaching for a central disc herniation with back pain only and an annular tear like that without neurology?
Basically nothing.
Yeah, non-surgical care. I mean, this is pretty harsh. He's had injections. He had.
Yeah, so he had it's not moving. Prolotherapy, stem cells, PRP, steroid, all with some relief, but essentially very temporary.
Now, there's a very controversial test, and I hate to bring that test up because the name is such a enigma itself. Discography. Did he ever have a discography?
So our diagnosis is an L5 fracture with subsidence of the implant into the vertebral body. He was diagnosed with osteoporosis at that time, and a DEXA after the lumbar disc replacement revealed a negative 4.4 T-score, and it was assumed to be from his anastrozole use and vitamin D deficiency. However, with endocrinology, he was found to have some rare heterozygous form of hypophosphatasia, which is a mutation in that specific alkaline phosphatase gene, which causes decreased bone mineralization. And he was started on Forteo and Strensiq, which is a extrinsic enzyme supplementation, very expensive drug. And here's a CT now, 2 years after that initial surgery. The patient is still having significantly debilitating low back pain without radiculopathy. His DEXA has improved, but you can see on our L4 to S1, the ROI at these areas around 65, so still very osteoporotic. And here's an MRI for completeness sake. And so here's standing lumbar x-rays, AP and lateral flexion extension. And so
was he again?
he was,
I mean, what are the risk factors for someone
59 years old.
That's really unusual.
And he's a very active, kind of muscular guy. So
That's really.
He's non-obese. He's one of those
non-obese.
high achiever people, mountain biking, ski
Let's see
racing.
the CT. Is that the CT?
Yeah, that's the CT now, 2 years
geez.
later. And so I think this, when we discussed it in the arthroplasty course, really highlights the fact that we need to get DEXA scans before lumbar disc replacement, which was a major criticism of this case, obviously. But then the next question is, what do we do now? And he's seen a few surgeons, and on the last arthroplasty meeting, there was discussion of some surgeons saying, just go anterior again and explant.
No.
In the setting of a guy that had retrograde ejaculation and an anterior hernia now.
Have they fixed the hernia?
No, so that none of that has been addressed.
Yeah.
And then second, there was a lot of people advocating for just posterior lateral
I
fusion.
wouldn't do anything.
Yeah. So
So he's the bottom line is he's worse.
He's
He has a
worse.
hernia,
yep.
and he has erectile dysfunction.
No, he did
Temporarily for 9 months.
for around 9 months afterwards. And so the question is, if I think we can go anterior, it's just whether or not we should. And is that an extremely risky operation? And I would say yes to that. So.
Forget it.
Yeah, no, this is a great case, and thanks for bringing that up again. And we apparently have technical problems, so anybody who can hear us, thank you for sticking it out with us. I lost my connection myself here right now, so I can't chat with anybody. So this is truly one of those cases that shows the dark side of spine surgery, I think. This is a highly elective situation. There are a number of factors that went sour. This is a very demanding patient. This is somebody who does Google medicine. He has a degree in Google Insights and dictates his own care. He has the means for that, and that's okay. And I think he was not pleased with American, he's from out of state, he's not from Washington, American physicians' conservatism, which is amazing, actually. And had a lot of extravagant things, including PRP done, stem cells. And so he went to Germany to have this treated. I totally agree with Zach, actually. Dr. Tartarin said, this is a simple discectomy, if at all, a posterior annulus and washout of the nucleus, not a crazy reconstruction surgery. And if at all, that would be the first nice surgery to do. In the Anglo-Saxon world, the use of discography has been a very long-held tradition for kind of this disruption, and it remains extremely controversial, and it's probably not practiced anymore. Since we're down right now, I had actually somebody online who wanted to comment on that, but that's going to have to be postponed right now. So a disc replacement should be truly a very wisely performed surgery and a well-suited patient. And I think the comments by our colleagues on our spine arthroplasty series were bone density should be obtained either with CT scans using Hounsfield units performed or a formal DEXA scan. And this patient, again, uses a variety of medications to try to improve his male function and adversely affected the outcomes of that. So this is a very big deal, and now he has a fascial hernia.
Yep.
And he clearly, there were some struggles in the lumbosacral junction. He clearly had a hypogastric plexus injury from the anterior dissection. So I saw the patient, I told him not to do anything, and we're getting a bone scan to see how this is settled. We're getting a SED rate to make sure there's not an occult infection in there. And we've agreed with him to modify his activities and to do, if at all, a set block posteriorly. But sensing where he is going, he'll probably need to have a posterior fusion for something that was a simple posterior annular tear. All right, let's move on. I'm still not sure we have internet access, so we'll have to proceed. But thanks for putting that together.
I have the lateral one too, if you want me to wait on that one.
No, let's keep going.
Okay. And then we have the slides. All right, perfect. For everybody just joining, if they're having technical difficulties, my name's Jerry Robinson. I'm an ortho fellow from Akron, Ohio, here at Swedish. So this was a case done recently. This is a 49-year-old male with Down syndrome and nonverbal developmental delay presenting with low back pain. Mom states that he fell in the driveway from a 6-foot-high structure about 9 months ago, and since then has become less functional. They sought no medical attention at the time because the patient was able to mobilize and seemed to have no injuries at the time. The patient now ambulates by wheelchair with a pretty consistent downward decline with persistent low back pain and has a pitched forward appearance when seated. By mom's report, he does not have any associated numbness, tingling, saddle anesthesia, and no changes in his bowel or bladder function. He obtained x-rays at an outside hospital, and then was diagnosed with a possible pathologic fracture. However, after a workup, the biopsy of that fracture site and vertebral body did not reveal any neoplasm. Here's his exam. At least anti-gravity in all myotomes, but very difficult exam as the patient can't really follow directions well. So that's variable. And then no other sensory deficits. And there you can see the pathologic or the reflexes. And so here you can see vertebral body collapse and some coronal deformity there from the asymmetric collapse of the L4 vertebral body and some sclerosis and bridging osteophyte. As you can see, this has been going on for some time. Here's a CT scan cuts that can show you that asymmetric collapse, and you can see some air in the vertebral body there, representing probably some avascular necrosis of that vertebral body. And here's the cuts of the MRI, and you can see that kind of asymmetric collapse there. And so, do you want me to proceed with what was done?
So why don't we go first and hit on some of our colleagues here. So what are some of the concerns when you have a nonverbal patient? You have a nonverbal patient and you're wanting to do surgery. What are some of the ethical challenges? What are some of the practical medical challenges in terms of outcomes?
Ethically, I mean, decision-making obviously needs to be exported to the patient's designated decision makers. In this case, that was pretty clear. He has a supportive family, so that was pretty easy to navigate around. In terms of the surgical outcomes, I think Jerry actually touched on the main issue. It's very difficult to establish a baseline for these patients, I think. There has to be a lot of detailed explanation to the patient's family that both in terms of gauging the exact outcome, there's going to be some difficulty. The patient can't participate with a full neurological exam, and then rehab will also be very difficult for a fully participatory patient. Rehab is obviously easier, but for a patient with this level of function, if there is any post-op neurodeficit or even an extended recovery, participation in ARU or SNF will be much harder.
I think you hit on all the main highlights. The main problem, practically speaking, is pneumonia, pulmonary embolus due to the lack of respiratory participation. It's very difficult to fine-tune that, and it's so important that patients participate in that. And as you said, then the rehab function, moving them around. And the practical solution is that, if at all possible, and this was very difficult during COVID, to have the closest family member there. And they usually have a amazing nonverbal or tactile kind of a proprioceptive feedback loop with them, and this is the case in the mom. So this is a big deal for that patient. They cannot reorient well. So Bob, you saw this case. What are your thoughts? I mean, this is obviously a devastating fracture that was kind of carried, or you have a microphone, dragged along for quite a while. Is this something that we should venture into surgery on? This young man became 40. His neck is normal. He has no other obvious medical problems. Should we operate, and should we go full bore or not?
Well, it is a harder decision in adults with developmental delay. This is it's an important part of a spine practice, these patients arrive, I'll say, not in huge numbers, but certainly regularly. And the histories are a lot of times, as this one is, that there's been a delay in diagnosis, even with neurologic deficit. And I think it's an issue of them not being able to communicate what they're experiencing, and it just takes longer to sort of sort out. And the patients in this kind of category that I've taken care of, they all arrive.
Recording in progress.
They all arrive with a very supportive family, because if there's not that kind of level of support around them, I think they never end up in the medical arena, right? Perhaps, I don't know, but I've never taken care of one where there wasn't a really supportive network, family network around them, and I think it's like with everything, it's a shared decision making, and listening to the history of this gentleman, it certainly sounds like he needs surgery. That vertebral body looks potentially involved with some sort of malignant process, possibly. I mean, I think we need to do that workup.
He actually had a negative biopsy.
And what was it? It was just fracture?
Fibrocartilage.
Just fracture.
Yeah.
So perhaps not, but certainly needs the workup, and if with or without that, I think with or without a positive result, she still needs. It's a female, I guess. She still needs.
It's a male.
Male. That's what I thought. Okay, he still needs surgical treatment. So, yeah.
All right. Why don't you carry us forward?
Yep. So stage surgery, first stage L2 to pelvis with quad rods and decompression, and then stage 2 for a lateral corpectomy. And so here you can see some fluoro shots of our decompression and fusion. There's just a scout image of that. Great bicortical purchase on the pelvis screws. Here we can kind of see after the corpectomy stage.
So we did a unilateral short screw on the corpectomy side. We did a posterior corpectomy to help our colleague, Dr. Skuin, and we thought that a far lateral approach would work. If you can go back to the AP image maybe beforehand. Rod, what are your thoughts in terms of a corpectomy and access to the L4 level? Traditionally, we did a retroperitoneal exposure. That's obviously the bifurcation issue always is a big deal of many. What do you use to predict whether you can get access to the whole body so you can get a corpectomy done?
I think for me, it's the plexus and the iliac crest. The L4-5 disc space on a lateral x-ray looked like it was accessible. So, and again, just you can see it there. We didn't have, I think the fact that you did a posterior decompression and corpectomy really helped as well. Partial corpectomy, you took a lot of bone out, so I think that helps. And then for me, the two main factors are the crest and the plexus. So if I can access the crest, I have had to abort. Sometimes you get in there and the plexus is right in the way. So fortunately for him, it wasn't. And I think, how much blood did we lose? Like,
Oh, it's minimal.
Minimal.
Yeah.
And once we got in, there was a cavity. We just dropped the cage in. So.
What do you do with the iliacs when you come in from far lateral? Where are they? They're obviously anterior to, but do you have to dissect them out? Do you have to somehow do something?
No, we actually start pretty posterior and then work our way up. And actually, I try to look at, with imaging, even on a CT scan, you can really see the vessels nicely.
I think you can see them here on this.
Yeah, you can see them there.
This axial.
So, but we really start posterior. You can see he's got a lot of retroperitoneal fat, and he's got really very atrophic muscles. In fact, when we went in, his internal oblique basically, like, normally it was like non-existent. It was like platysma. It was very thin.
Again, we don't have access right now to our speaker, which is sad. How do you close this? We were always taught we did anterior procedures to do a two-layered closure for fascia, so internal obliques, external obliques, together the transversus.
So we don't cut the internal oblique and we don't cut the external oblique. And we do try to close the fascia and then try to put some nice big subcutaneous sutures. But we actually just dilate through. We didn't use once you get through the skin, we just use peons to go down.
His psoas too acted like a closure too. When we pulled the retractors out, it basically closed and you couldn't see anything that he did. It was great.
I mean, literally, his incision was like this big.
And one other thing about far lateral procedures that we've seen sometimes is these kind of pseudo hernias. So unlike the previous patient that's presented with a real hernia, pseudo hernias are where the obliquus basically bulges out. Why does that happen? And is that something that's more prevalent in upper lumbar than lower lumbar approaches?
Happens in all lumbar approaches. Most of the time it's temporary. Because like I said, we don't bovie. In fact, on his, you can see one of the intercostal branches.
Yeah.
I mean, you can, there's no question that that can happen. And typically they kind of present with abdominal wall paresis. And then you think they have a hernia, but it's not. It's just the innervation of the intercostal muscles.
How do you test for that, and what happens with that?
So you get a CT of the abdomen. Usually there's not really a test. You can just see it clinically, and you can see it on a CT scan. And then a lot of times we just do like a soft abdominal binder. Again, I've probably had 5 or 6 of them. And about, I'd say half of them were permanent and half of them, it was temporary.
Dr. Santarosa, can you hear us?
Yes, I can hear you.
Fantastic. I so apologize for the technical problems this morning. Just like Facebook the other day, we had some Zoom outage. So good morning in Dallas. Is that where you're calling us from?
I am.
Great. I voiced a conflict of interest before. I'm from UT Southwestern myself, and we have another surgeon here, Dr. Right back here, one of our plastic surgeons. He's also from UT Southwestern, Dr. Gottlieb.
Oh, yeah, fantastic.
So we're heavily in favor of whatever you have to say. So we showed, as a first case, a very active male who had a disc replacement in Germany as a medical tourist. And he has a large anterior hernia, and he had male sexual dysfunction afterwards. That's partly resorbed. He has a complication of disc replacement now. And the second case is one of a far lateral approach, a XLIF. And there's so far no problems. We talked about these bulging abdomen presentations that some patients have where the lateral abdominal wall kind of just bulges out, a pseudo hernia. So let's start with the latter first. So is there anything that you've identified as being causative for this? And what do you tell patients when they say, I want this gone, I want this bulge gone?
So for the pseudo hernias, just like the other surgeon was saying, that anytime you use bovie, you're going to risk actually transecting the neurovascular bundle. So again, we use blunt dissection just like he did. Sometimes you get it. Most of the time, I will say that it is just transient, comes back within a year most of the time. Very rarely do we ever send somebody to the plastic surgeon. I think in our practice with 4-axis surgeons, we sent 2 people to a plastic surgeon to do some sort of plication procedure that can kind of temporize the issue. Again, these are very difficult patients to treat, so we do actually warn them fairly heavily on the front end that this is a possibility that it can happen. In terms of the actual ventral hernia, I will say in the literature from the general surgery standpoint that if you have a BMI over 30, 35, your risk of herniation is going to be much higher than below that. And they actually say in the hernia literature, if we have to do repeat incisional hernia repair, your recurrence rate can be as high as 30%. So I will say it's something to warn your patients about on the front end if they are on the fluffier side.
So great point there. For trisomy 21 patients for Down syndrome, are you aware of any connective tissue diseases that makes them more prone towards kind of instability, hernia, anything like that?
Any general connective tissue disease, Ehlers-Danlos, things like that will make you more prone to that. You just warn them on the front end. I'm not sure I would do anything preventatively any different. You just warn them that they're going to be a higher chance of having some sort of mesh repair on the back end.
But you'd never put in a mesh repair as a first primary procedure, would you?
I haven't. They've actually studied that too in the bariatric literature, and they actually found that the complication rate for putting in that mesh was actually higher than actually letting the hernias occur on their own. So they've actually gone away from that in the bariatric literature, and that's why I've tended to stay away from that as well.
So I'll put you on the spot. We have a plastic surgeon here, the aforementioned Dr. Gottlieb, and you said send patients with these bulging abdominal walls to a plastic surgeon. I had 2 patients, and I sent both of them to you. And you said no to surgery. So what are the options, and what's so difficult about trying to kind of tuck that in?
Best option is an abdominal binder. You quoted a 30% recurrence rate. I haven't looked at this in years, but my understanding, even from residency, that it was a little bit closer to 100%. And we always tried to steer away from them because we could make the patients as likely make them worse as better.
Yeah, the recurrence rate for the ventral hernias, but for the pseudo hernias, yeah, I agree. We actually try to treat them with binders. There are some plastic surgeons that have attempted to repair this, but we tell them it's not permanent. And actually, it causes them a lot more pain on the back end.
Okay. Let's have Dr. Pratt come up. Yeah, Jerry.
I was going to ask one question. For access surgeons, is a patient that's had previous retrograde ejaculation or other plexus problems, does that tell you that you should not go in, or is that a red flag for you to say no rather than attempt the surgery?
I think you really have to have a well-documented conversation with that patient on the front end and kind of have a task team approach to how bad that patient's back pain really is. There's patients that walk into my office and say, "Hey, docs, 10 out of 10, I don't really care anything about retrograde ejaculation, just fix my problem." So if they're willing to go through that and it's well-documented, I think that's really the driving factor. If they say, "Hey, doc, it's not too bad, I want to have kids," things like that, then maybe I would think differently.
That's a great point. So if we have to go back in, you missed that case, and we have to kind of move on with more cases. Would you then go from the ipsilateral side or the contralateral side? This patient had a midline incision that basically now has about a 2 male fist size abdominal protuberance. So first of all, we have to go through that center, but would we then go on the same side, which is the left side, or would we kind of go right retroperitoneal, or would you go transperitoneal?
Which level was that? 5-1 or 4-5?
This is the L5-1, yeah, L5S.
Oh, so 5-1, yeah, for 5-1, I would actually just go on the other side. It actually is pretty much virgin planes. Once you find the disc base itself or the total disc, you can kind of scrape everything right off. It's actually a fairly easy procedure to do from that side.
And since we have a source of authority with you here, is it more risky? Our boards ask that all the time, so I'm going to put you on the test stand here. Is it more risky to go transperitoneal, and why so than retroperitoneal?
I would say, from what I remember, the transperitoneal, I think there's a higher risk of retrograde ejaculation with transperitoneal approaches. The other thing I don't like about the transperitoneal approaches, I can't visualize the ureter directly, especially in a redo operation. So those are the things that I worry about the most. If I come from the or the contralateral side, those planes are free, and I can actually see the ureter and everything else. The only thing I need to do is find the edge of the iliacs and move on. So
Great.
That's why I prefer that. I can't see the edge of the veins either.
Super. Thank you. So ready for our next case. Right. Dr. Nathan Pratt, please introduce yourself and show us what you got.
I'm Nathan Pratt. I'm one of the other neurosurgery fellows here at Swedish. I trained at University of Maryland. And I have a quick case for us that we actually just recently took care of. Patient still in the hospital of a thoracic disc herniation in a very complicated patient. This is a 38-year-old female with a history of morbid obesity presented to an outside hospital with new onset of bowel and bladder incontinence, bilateral leg weakness, inability to ambulate, and diminished sensation from about her navel down to the bottom of her feet. She began noticing worsening unsteadiness and weakness, sensory loss, probably about 2 months ago, but this was not enough that it brought her to medical attention. She eventually started using a walker, had multiple falls. This worsened. This was occurring like acutely in the last 2 to 3 days. Prior to admission, she developed the urinary incontinence, and the profound weakness in her legs had developed maybe within 36 hours of the time she came to the outside facility. She also came in because she was having bad chest pain, shortness of breath, found to have an acute pulmonary embolism, which was treated at the other facility with IVTPA, and was started on a heparin drip and was transferred to Cherry Hill here. Her past medical history is just significant for obesity and a prior tibial fracture that was repaired, and no significant surgical history that we would be interested in. Otherwise, everything else was fine. Neurologically, she had significant weakness in all muscle groups of the lower extremity. She was unable to accomplish any sort of full range of motion or anti-gravity movement in any of her lower extremity muscle groups. She also had reduced sensation of light touch from the navel to the toes. She reported almost complete anesthesia in the saddle region, diminished rectal tone. She said she could occasionally feel when she needed to pass stool, but she could not sense her bladder at all, and had a Foley catheter placed with significant urinary retention at the outside hospital. We were able to obtain a MRI and CT scan. You can see at T1011, there's a large disc herniation with significant canal compromise, deformation of the cord. Not clear if she has any early signal change. She also has the CT scan here showing that this is a calcified disc. So clearly a chronic issue. However, she acutely has gotten worse in the last few days. So because of her...
Yeah, so let's go back. Let's go back.
Please.
So Dr. Schonert, can you hear us now? Neil, can you unmute yourself?
I can.
Great. So calcific thoracic disc, lower thoracic spine. Before we go to Dr. Santarosa and ask her how she wants to get us there, what makes calcific thoracic disc so horrible? And I know you have a very amazing educational pathway from UCSF through Rothman. What were you taught how to treat those?
This is quite problematic because you're going to have a real difficult time establishing the tissue plane between the protrusion and the anterior surface of the dura. So it's going to be problematic, and this has to be, you have to remove it in a manner that allows you easy access, because you're not going to be able to develop that plane very well. So you'll be going from inside in to get rid of this disc fragment rather than from outside.
What would you do? Would you go posteriorly? Would you go laterally, anterolaterally?
I do a partial corpectomy above and below to try to establish the plane of the dura, because at the level of the protrusion, the likelihood that you find that plane without significant challenge or CSF leak is very low. But at least if you have the parameters, I do a hemicorpectomy above and below and try to mobilize into the disc space. Julianne, welcome. We can see you now.
All right, so a good discussion here. So you said the CSF word. So the two main, actually there are three main aspects of thoracic disc herniations. Historically, with anterior procedures, there was roughly about a 10% risk of wrong level surgery. That's become far less now with a more posterolateral based approach. The second biggest problem, and probably the biggest in terms of patient impact, is paralysis and secondary neurologic deterioration. You can do everything fine, and due to a number of circumstances, that's surgeon manipulation, that's reperfusion trauma, to name a few, patients can experience a very unfortunate neurologic deterioration, even if everything's done well. The third thing is now where our access surgeon is immediately called upon. If we go from a lateral, anterolateral approach, we'll obviously be in the pleural space. And Nathan, a central large, this certainly qualifies as a large calcific disc herniation. Dr. Shauna talked about a plane. What is commonly suspected or worried about when we do an anterior procedure of a large calcific disc?
So you're concerned that this could be directly attached to the dura. If you try to resect it and you get a CSF leak into the pleural cavity, treating that becomes immensely difficult, if not impossible. I mean, you're probably going to end up shunting that patient, hoping that that works. They've got negative pressure constantly pulling CSF out. The chances that they develop some severe complication up to like a huge subdural hematoma and death is entirely possible. This is a CSF fistula. It's almost impossible for you to repair from the front, and you've created a large cavity in which that fluid can then flow. If it's posterior, at least that's contained. You can close the fascia. You can attempt to, even if you can't repair the dura, if it's something where there's no way to do it, you can go back, patch that, try again, lumbar drain. Eventually that could end up with a shunt too, but at least in that case, it's all contained within a cavity. inside the pleural cavity, I mean, this could leak forever. I mean, it's a devastating problem for the patient.
And one of your faculty at your institution, actually, he's a great surgeon, very honestly wrote about a case report of a death after, you know who I'm talking about,
Yeah.
a death after a syringopleural fistula, despite expert management and recognition. So, Dr. Santarosa, this is a pretty nasty curveball. Are you asked to do these kind of lower thoracic discs sometimes from the front?
We lost the Zoom again.
I sense that. Great. That's frustrating. Dr. Shawner, you're off also? Okay. North Korea or Iran or Facebook conspiracy. Facebook is blocking other providers now.
Yeah, Zuckerberg is sitting there pressing buttons right now, telling us what we can and can't do.
The border, what's it called? BGP, the Border Gate Patrol. That's that thing that's that software router.
Is it?
Thing, yeah. Well, let's just carry on
And we can
and show this.
at least. I mean, I think that, the history stuff here, that her cardiac status and pulmonary status actually improved within 24, 36 hours of her getting the TPA, which is fantastic for us. We still wanted to go ahead with surgery. She was so early in her time course, needed the decompression. I think Dr. Shawner said exactly what we did. We took her for posterior intermittent fusion, did transpedicular approach. Some people might have gone all the way out to the rib head. Wasn't necessary in this case at all. Just going transpedicular was a perfect approach here. Partial corpectomies. We were fortunate that we were able to develop a plane. I mean, this was not completely adherent to the dura, but that was the longest portion of the case, was that, trying to develop that plane. Very uneventful, minimal blood loss, given what we were doing. Patient extubated at the end. We map augmented her and kept her on high-dose methylpred for 24, 48 hours, and she improved significantly. She was actually improving before surgery, even because we had her on some dexamethasone. But regardless, here's our postoperative scan. You can see the entire disc is gone. We were able to take all of it away and create a large, cavity here that we filled with a small peat graft. And this was an outstanding recovery within 24 hours, actually less, 12 hours after the operation. The patient's moving her entire lower extremity with about 4 out of 5, almost 5 out of 5 strength. She has return of bladder sensation, bowel function. She's got almost normal sensation in her lower extremities. Other than back pain, she has no real complaints right now. She's pending dispo. There's a drain that's still sitting there, but she's almost back to full strength at this point, and is recommended to go home. Actually, doesn't even need to go to spinal cord injury rehab or anything. So a very good outcome for us.
So thanks for showing that. Can you go back to that CT scan? So Bob, this was one of those nightmare situations. This woman had an unrecognized thoracic myelopathy, lost ambulatory function. She actually had all the warning signs. She broke an ankle on one side. She had a tibial plateau fracture on the other side. She's a nurse, but nobody picked up that she had a myelopathy. So now she has an acute saddle embolus. It's a very impressive. I thought you'd show that CT, but that's okay.
Oh, I don't have
don't
that.
worry
Sorry.
about that.
I should have
But
put
it's
that
a pretty
out here.
impressive saddle embolus, truly straddling left to right hemisphere. She is oxygenating okay, though, on room air, but she needs positive support. I was amazed how rapidly our intensivists allowed us to proceed. This woman had acutely deteriorated neurologic status. What have you done in the past in terms of operating on a patient who needs to be acutely anticoagulated? I know we have different opinions in terms of when to restart things, but what had you been doing in the past at OHSU in terms of anticoagulation, and if you have an acutely ill patient like her?
Well, neurology does trump some of these other medical issues, right? So ideally, you would wait and let the clot dissolve. I would probably put a filter in preoperatively and then proceed with surgery. If her neurologic status is deteriorating acutely, then you don't have that luxury. I think I still would put a filter in preoperatively.
She did. I don't think I mentioned it, but she
Yeah.
did get a filter.
Yeah.
We didn't? I thought we did. Oh, we did?
Yeah.
Oh, okay. Critical care didn't want to do that.
We'll at least have the discussion, but that would be the consideration. I think this kind of surgery in the midst of ongoing anticoagulation would be very difficult to complete. So I would be very hesitant to do it while she was on chemical anticoagulant. But I agree with everything that's been said. This, for me, and back in the day, we would have done this anteriorly. It would have been a knee-jerk reaction that this needs a thoracotomy and a corpectomy from the front. And I think this is a much better and much safer approach for all the reasons we've talked about, and CSF management maybe being the most pressing.
Nice.
We've had ongoing internet problems, so sad. Julianne, can you hear us? No response there. Rod, any thoughts? So thank you, Bob, for your discussion on this. So we went posterolateral. How do you visualize the front of the cord? Do you have any tips or tricks in terms of how to look around the corner? Some people have talked about endoscopy nowadays, using thoracoscopes or something like that. Any thoughts of doing this through a far lateral approach? You're very facile with these X-lifts.
I mean, I think you guys did a great job. I think you went transpedicular.
We went transpedicular bilateral, above and below.
Yeah.
Just like what Dr. Schonert said, did a subtotal corpectomy.
Yep.
I mean, I think the key thing is, and you guys did this here, you can't do a small. The mistake people make on these cases is they'll try to do a little, like, one-level laminectomy. Mm-hmm. And that's where, you basically the cord will herniate backwards and you won't have enough exposure. I think this is a great outcome in a very difficult case.
All right. So what we actually did was we used a 70-degree scope, and we actually didn't have to use it for dissection. We just used it for confirmation in the end. And we used the Roten dissectors. The Roten dissectors were above and below, so we could establish healthy dura above and below. And then once we got the main fragment isolated as an island, we kept gentle traction on it whilst we teased it off. And there were obviously the usual careful moments of when we separate it off, because there's a gentle pull involved, and but there's no rebound, and there was no reperfusion trauma, fortunately.
No, it was great. Yeah.
And we actually had, interestingly, we had no SCPs, but we had MEPs, and we were able to preserve those.
Mm-hmm. Yeah, I think the SCPs improved, didn't they, by the end? I can't remember. But either way, another thing that we would do at Maryland, probably not necessary, but that we've used before, is ultrasound to visualize. Not necessary, but at times can be helpful. If you don't know if you can get the entire disc, if it is very adherent, have you done enough that it's decompressed? Is the cord free flowing? Do you see that movement, that pulsatility intradurally? And then you can say, well, let's stop before we cause a problem. But we didn't need that in this case, but also an option that we've pursued before.
Dr. Santarosa, can you hear us again? I keep getting conflicting messages whether you're on or not. So this is a favorable case. Obviously, these are always very difficult cases, and we tell patients still to the present day 10% risk of paralysis, 10% wrong level surgery, a unknown risk of paralysis. And in her case, to talk to Dr. Hart's point, we actually discussed a filter. I thought that this would be a clear yes, and our pulmonologist actually said no, because we got bilateral lower extremity Dopplers, and she had no lower extremity clotting phenomena. So with clear lower extremities, they felt up to the lower end of the IVC where they could visualize her. They felt that there was not a filter necessary. They treated symptomatically. They felt in a large patient like her, the problems of a filter would be higher than the benefits. So that was an interesting concept, because I was like you, I said filter, and they surprised me by saying no. We converted on heparin and had an 8-hour window in which we operated on her, and we restarted her very aggressively, I think after 12 hours with soft start heparin, so we did not bolus her. Rod, any other thoughts about anticoagulation in this setting, and when do you restart anticoagulation when you have an ongoing VTE problem?
I mean, I think restarting it is, it's kind of, people don't, I think not bolusing, I think is probably the thing I think you guys did a pretty, just in terms of anticoagulation, I think you had a small window. So I think restarting it is fine. I also think I think you could do Lovenox. That's an option as well. But it sounds like, she had a pretty big saddle pulmonary embolus. So I think, initially to get her on. And then are they switching her to, what are they doing? Eliquis? Coumadin.
Yeah,
okay.
we're going to do Coumadin on her.
Yeah, I've done it before in the past where I actually will start Coumadin on post-op day 1 because it takes about 10 days for them to normalize. So that's another option if you want to slowly get there.
We're in the crossover right now. Let me talk about her obesity. So first of all, the obesity here, this is not body shaming. This really led to a very precarious, life-threatening condition, this patient, and she had unrecognized myelopathy. What is the state-of-the-art closure, Dr. Gottlieb, our plastic surgeon, in a patient with a BMI of 50? Again, this is an ongoing issue. Basically, we're well over a hand width thickness of sub-Q fat. So how do we close a patient like this to be reliable?
Great care, gentle care. I typically like to remove all the little pieces of devitalized muscle at the edges that happens mandatory from the retractors that are used, and then closing in as many layers as possible. I try to close the paraspinal muscles first, then latissimus and trapezius. I usually prefer using monofilament sutures. I typically use PDS here, not trying to advertise, but I prefer not using sutures that have interstices for bacteria to sit in, and just gentle handling of tissues. And frequently in someone like this, we might use a Prevena, a negative pressure dressing, which increases capillary blood flow and helps in wound healing. We still see wound problems despite all that.
So what do we do with it? What do we do with the sub-Q tissues? Do we do a multi-layered closure? Do we close scarpus fascia?
If
Do we
there's a
drain that
scarpus
space separately?
fascia, I will try to put some sutures in that also. Otherwise, fat won't hold anything. And it's easy to be deceptive if it's a redo that the scar is going to hold something. It'll hold it to put your suture in, but you really just have a foreign body with no benefit.
It's great to have you here with us. I'm going to keep pushing on you a little bit and see whether Zoom restarts at some point in time. Do we put a sub-Q drain in? I always put a sub-Q drain in these larger patients, put it out through a separate portal. Is that beneficial or not?
I think that's beneficial. Many of these patients you can sometimes frequently see them weeping liquid fat from these during the procedure, and being able to evacuate that in a controlled setting is better than letting it drip through the incision.
So talk about this liquefaction. What is it that liquefies, and why does it liquefy?
Some of it's probably fat. Most of it is interstitial fluid. I mean, the patients have retractors in, often very long procedures, tissue damage, and with the edema that occurs, it eventually has to drain out somewhere. And in these obese patients, it's typically not going to be picked up by their capillaries. It's just going to collect and hopefully be removed with a drain.
This patient, interestingly, we put in a large drain system subfascially, and we put a subcutaneous drain in. And the only drain that's still putting out right now is the subcutaneous system. The large system is dried out, so that's interesting. What do we do for skin closure? So I'll give you my hypothesis. Staples and resorbable sutures in these very large patients are a bad choice. One dissolves too fast, and the other irritates the skin too rapidly, so that they have to be removed prematurely, and the skin hasn't matured yet. Is that just my conjecture, or is there some truth to that?
I'm really not sure. Staples are faster. The last patient of yours that I used staples on, at the end of the procedure, her temperature was 33 degrees. They couldn't get her warm, so we closed it as quickly as we could. But in general, in the obese patients, the staples only come one size, and it may not be deep enough to have the kind of closure you can do with suture. You always have more control with sutures, but they do take a lot longer, at the end of what's often a very prolonged procedure. So there are advantages and disadvantages, and they've got to be balanced with each case.
So I've been told that Dr. Santarosa is giving her talk now. We'll switch off there. Thank you, Dr.
Thank
Pratt,
you.
for sharing this and
Yes.
putting this together and for all the discussants. Ben, Linda, Alexis, can you switch to Dr. Santarosa's talk, or what are we doing here? Okay, this is Alexis.
Sorry for the interruption, Dr. Santarosa. We just got back up again. But you can continue.
Okay. A lot of times if we lose that fat plane, that vein flattens out, just something to be aware of. But a lot of times we can move that vein towards the end of the case, at least a centimeter or two by the end of the case. And you can usually put a disc or a cage in directly. Again, something to watch out for too. The vein's starting to flatten out a little bit. This is a midline vein. You don't really have a great lateral corridor. Looks like the vessels will move on the right side, but you don't have a great corridor here. So, again, this is going to be something based on the level of your experience of your access surgeon, as well as your spine surgeon itself. That's why it's very important to look at the imaging and have a conversation between the two surgeons and what you realistically can and can't do. Okay. So again, does anybody notice anything different about this case, or can anybody tell me or comment on this at all?
Hi, Dr. Santarosa. So we had a parallel universe going on. I heard you started the presentation, and we're still doing discussions of lower thoracic disc herniations. I'm worried about the kidneys, where they're very posterior, or they're very lateral. That's an unusual thing for me. I'm not sure why that would be. We're at the L2-3 disc space. Vena cava versus the aorta, I'd have to scroll through the axes a little bit more. It looks to me like the aorta is dead center and the vena cava is on the left side, if that's not a flipped image. I'd certainly want to have a kidney ultrasound because I see some heterogeneity in the medullary portion of the kidney. So I'll shut up.
No, you're exactly right. This is something that I actually see 2 to 3 times a year. And if you guys aren't looking at this imaging and you start approaching from the left side, you're going to run into that vein. Not to say it can't be done, and sometimes we actually do it on purpose. But if you're new to access, new to A-lifts, this is the type of case that's going to get you. So this is exactly right. You nailed it. It's a left-sided inferior vena cava.
Great.
Okay.
Can I ask you a question quickly? I know you're not a urologist or a nephrologist. I always, I had a couple of patients where I actually found a hypernephroma. When should I send a patient to a ultrasound, or should it be an ultrasound or something else when I see kidney anomalies on MRI scan? Just very brief aside.
So if we find them relatively, a lot of times, I'm not actually able to access the images till shortly before the case. But the spine surgeons that I do work with, they will work them up with ultrasounds and MRIs and actually send them back to their PCP or nephrologist if they have one ahead of time. Because if they have a compromised kidney on one side, again, that's very helpful to know ahead of time before that case even starts. Sometimes you may want to mitigate that, so with something like ureteral stents, if it calls for it, things like that. So, I would actually address those issues again with the kidneys very much so on the front end.
Great, thank you.
Here's some other venous anomalies. This is something that I actually see a couple times as well. I don't know if you guys have ever seen this, but we call this double barrel IVC. This actually looks pretty scary. This is just actually very high bifurcating iliac vessels. This is actually a very easy case to do, believe it or not. You don't really have to mobilize anything. A lot of times you can just sneak in between this space right here and just move everything over to the side. And it actually moves quite easily. I've never had an issue with one of these cases, but if you haven't seen it before, you'd probably want to know that you had this on the front end before you go barreling and trying to move things over, because you'll tear something.
Let me ask you a question. My good friend, our good friend, Dr. Mike Jansen, published an article under, I think the first author was Matthew Data, to get a CTA, and he found in a series of, I forgot what, I'm making this number up, 20%, 30% of patients, significant anomalies that changed his whole concept about what treatment should be rendered to the patient based on CTA data beyond MRIs. What are your thoughts on when should we get a CTA? Is this something we should have a lower threshold for? It seems that it's ordered less now than more.
So we've actually started to order them more now. We weren't really ordering in the beginning of my practice, but we've actually started more now, especially if the patient have any kind of atherosclerotic disease or if they have any kind of PVD in their history, because the calcifications and things like that are something that you really want to be aware about they don't really show up on an MRI. And so those are one of the biggest things. The last thing you want to do is find out that you've dissected something off and had an issue with it or a stenosis somewhere that you didn't otherwise know about. And again, those aren't appreciated on an MRI. So if they have any inkling or, heavy history of smoking use, things like that, you're kind of at a place like yours or a level 1 trauma center where you're not treating the young, healthy yoga patients, that's going to be more of an issue and something that you should be aware about and ordering them kind of routinely. We're actually trying to set up a protocol here in the Methodist system to kind of identify those patients and who should get them routinely.
Thank you.
But yeah, I agree. Again, this is going back to that case where the access surgeon actually lost his license. Does anybody notice anything different about this one?
Let me put Dr. Hart on the spot. Bob Hart is right here.
So this was an anterior approach to 4-5, or what disc was approached?
I guess 4-5, maybe.
Yeah. Well, the kidney is, again, in somewhat of an anomalous location there. And I don't know if this is a patient with maybe a solitary kidney or what the issue is, but it ain't exactly normal.
No, it's not normal. So this particular access surgeon did not look at the imaging ahead of time, found what he thought was a mass, took it out, and thought he was being a hero, and it turned out to be her kidney. So,
wow.
And there's really no excuse for it because the imaging was there ahead of time. So that's why I stress.
Since you said the kidney word, Dr. Graniello is asking horseshoe kidney. So how do you see a horseshoe kidney on an MRI scan?
Again, the kidneys are going to be up higher towards your kind of your L1, L2 disc spaces. So, unless you're doing a 5-level A lift, it's not something that you would really encounter. What you do want to encounter if you're doing, we routinely do 4 levels, sometimes even 5-level A lifts here in Dallas, is the retrocaval renal artery, the kind of one instead of going in front of the aorta, it goes behind. Because if you're starting to get up into that space and you're dissecting into that space, you're probably going to run into it. So that's the thing I worry about the most, with the horseshoe kidney as well. You're going to worry about those things again ahead of time. But that's something that you say, hey, maybe we just stick to the bottom 2 levels and, you can come laterally for the upper 2 levels or do a single position ATP approach with lateral A lift at 5-1.
Now, let me
you have options.
Yeah, let me ask you another kidney-related question. So in our monthly disc arthroplasty forum, which has a lot of Dallas area Metroplex surgeons in it also, but it's a very cool forum. We'd love to have you there in the future. We actually had one of the more remarkable sessions of many last month where a spine surgeon himself showed his own spine saga. So this is not some abstract patient. This was him speaking, and he had a 3-level anterior lumbar disc replacement, L1, 2, 2, 3, 3, 4, done to himself. If I asked you, Dr. Santarosa, can you give me a straight AP access so I can get to L1, 2, what would you do to me?
We can do it. I'm not saying it would. We've done it, and so. Is it hard? Yes. A lot of times what you have to do here, sometimes you get lucky and you can just slip right up there right next to 2-3 and kind of get it just from a regular retroperitoneal approach. Other things that if you don't do that, you actually have to kind of go behind the esophagus, kind of dissect through the kind of in the retroperitoneum, split the aorta and the vena cava and access it that way, all the way up at 1-2. Would I recommend that? No. Absolutely not. Yeah, but you can't do it. It can be done. Should you do it? I don't know.
Yeah, we were all speechless about this pretty much because when we asked him for the details, he's a neurosurgical colleague. He practiced in Beverly Hills, nationally known colleague. None of us knew what he'd actually been through. But basically, they fold up the kidneys on both sides and pull them under the hemidiaphragm to get to L1-2 eventually. So the FDA was, it worked. Yeah, we all thought this is wild. And then there were several other colleagues from around the country who went like, oh, yeah, we go to 1-2. And I'm like, wow. first of all, it's not FDA approved above L3-4. And again, I would be just very, very worried. And we've seen patients here who've come to us who've had renal artery injuries, even from trying to get to L2-3 with far lateral approaches. So being aware of where the kidneys are and where the renal artery runs is a big deal. For common practitioners like myself, how can we kind of visualize or conceptualize how high the renal artery or where the renal artery runs? Is there any way short of a CTA to establish where it is?
Sometimes you can see it. Let me see if it has it on the roadmap that we did here. Sometimes you can actually see it right on the MRI itself. Usually that's going to sit around L1, L2 anyway. But yeah, I mean, like I said, you can actually do exactly that. You can slip right underneath the kidneys itself and kind of pull everything up that way. But, a lot of times you can just go up there and split the aorta and the vena cava behind the esophagus, which I actually found to be a lot less traumatic. We've done it a couple of times, but not something it's a little terribly exciting for me to be able to do.
Yeah, no, I think the vast majority of us were aghast when we saw the images and heard that. And the more we heard about the dissection access saga, the more we went like, that is wild. But there were, again, colleagues from noteworthy centers who said, oh, yeah, we do this. So that was shocking for us. So since we have you here, let me ask you some practical and then some bigger picture questions. You mentioned atherosclerosis before. This is a big deal for me. So I actually trained as a general surgeon first in Germany as a trauma surgeon, and we were always really worried about when we saw plaque, more or less circumferential plaque, to do anterior exposures there. The thought was we can basically loosen them up, and we actually had intraoperative embolic phenomena there. So what is your threshold to say no to an anterior exposure if you see plaque, and how should we kind of work those patients up? I saw your risk stratification slide there.
Yeah, so I mean, this is a risk chart. Let me go back to, there's a couple x-rays that we had. So a lot of times when I see somebody with plaque, if you see, you have your lead pipe here. If I see this, I mean, look, this is going to be a very tough case to do. We actually ended up, I believe on this case, we ended up doing a 4-level ALIF on that person, but he actually went to the spine surgeon. I think he went to like 4 different spine surgeons. TBI actually turned him down. He went to a couple different access surgeons. He saw us multiple times within the group. He really wanted an anterior approach, and we kept telling him, this is not safe. You shouldn't do this. These ones, you should really stay away from. But we had a well-documented thing. Hello?
Yes, we're here.
Okay, sorry, I don't know what happened.
Yeah, we don't know what happened.
So, well-documented. Conversation with the patient. We ended up doing a 4-level ALIF on this person, but we were very careful to when we did it to not really wrench one part over. We actually took everything out widely, and when we moved everything over, it was kind of in an arc rather than just pulling over at the one vessel. And we didn't move it very far, and we actually slipped the cages in underneath. So with a lot of stuff, you can do that. Would I do that? No, not in a regular thing. You should really stay away from kind of these lead pipe things. If they had, this is actually kind of what a stent looks like preoperatively. These were actually ATP cages that we put in. I think this patient actually shot himself or something like that and had that kind of stent or something like that. But I would actually work this patient up with a CTA. Now, a little bit of plaque, I mean, that's just your basic spine surgery or your spine candidate. Unfortunately, they're going to be older people, a little bit of plaque. We just kind of accept that risk and kind of go over like, you may actually clot off something here, and we have to be prepared for that.
Do you use pulse oximetry on toes or something like that to make sure in at-risk patients that they don't? Yeah, on both sides?
Yeah,
both sides? Yeah, so it's something that I don't see done in a lot of places, and that includes us here. Bob, do you use, for your anti-approach, do you use pulse oximetry on that leg?
I don't insist on it, and I'm thinking I should. So I really don't even have the answer to that. I don't think we do.
Yeah. When we use pulse oximeter on left great toe, because the last thing we actually document 100% or 99% stats on the left great toe before we close. Because if we have a clot, the last thing we want to do is find it out in the recovery room. We're going to find it out right then and there.
A classic question in our board exams is also basically going towards the sympathectomy effect. Is this something that you see commonly where you have a hyperperfused ipsilateral to the approach limb, and the contralateral side is kind of constricted, pale? Do you see a sympathectomy effect quite often if you have more extensile anterior exposures?
I wouldn't say often. Again, I would say it's, it can happen. We've seen it, usually with the big deformity cases, we do mission work over in Ethiopia, and those are pretty severe cases. And so we may see it over there. I've heard of a couple of cases over here in Dallas. And again, they're with the, older, large scoliotic, very stuck, can't really identify anything. Everything is scarred in type of case. So it does happen. Patients recover fairly quickly. We've never had anybody complain long term, though.